this session, acting clinical nurse consultant Ross Proctor demonstrates how to do a cardiac assessment. As problems with the cardiovascular system can affect the whole body, you move systematically over the body to conduct this assessment. A cardiac assessment requires a systematic approach of looking, touching and listening. You assess the body in the following order: whole body, chest, limbs, jugular venous pressure, heart, point of maximal impulse, and finally lungs. But first, you conduct a primary survey, or ABC. Then you take the patient history with a particular focus on cardiovascular risk factors. Ask the patient why they came to hospital. Ask them what they were doing when the incident occurred and if they are experiencing any other symptoms. Keep in mind that patients may not always present with typical chest pain. The European Society of Cardiology states that the term chest pain encompasses a constellation of symptoms suggestive of myocardial ischemia, which include dyspnea, palpitations, syncope, and diaphoresis. Find out how old they are and if there is a family history of heart disease. Get a clear picture of the patient's cardiovascular risk factors. These include diabetes, obesity, hypertension, dyslipidemia, smoking and depression.
Oh, that's good.
As far as I'm concerned, it's probably okay.
Yeah, well, we'll check it again and let you know.
Yeah.
After taking the patient history, you begin the cardiovascular assessment. Observe the patient's face and general appearance, including their dental hygiene. With your index finger, pull down the patient's eyelids.
And just see if they're nice and pink or not. It could indicate they're anemic if it's pale.
Next, you inspect the chest.
We want to just sort of look at the person's chest to make sure they haven't got the obvious deformities that might indicate they've got respiratory disease or something like that. If they've got any scars, if he'd have had a scar on his chest, it might indicate he's had surgery he forgot to mention, because people do forget things.
Physical signs of cardiac pathology are visible chest palpation, cachexia, ascites, pallor and peripheral limb discoloration. Next, you take the patient's pulses bilaterally.
Because we want to make sure that they're similar in strength and amplitude. Thanks, Andrew. And then we'll have a look down at
Then you palpate the patient's ankles.
See if there's any obvious changes in his ankles indicate vascular disease, discoloration, or if he's got any pitting edema in his ankles, but they're all fine. Feeling his
Then check for pedal pulses on both sides. There are 2 pulses to check on each side.
Pulses. So there's the dorsalis pedis, which is just off the tendon down on the top of his foot around this region. So we're going to feel those bilaterally.
The second is the posterior tibial pulse,
which is just behind the malleus on the tip of his tibia here, his ankle. So again,
as you did with the radial pulse, check for equal strength and amplitude.
So the pedal pulse is...
Pedal pulses may be difficult to feel at first.
Yeah, so you just have to feel around till you can feel them, and don't press too hard or you obliterate the pulses.
Oh yeah, found them. And they're the same strength and simultaneous. And the second one under the...
Yeah, under the malleus here. They're usually a little fainter.
Yep, found. And they're equal in strength as well.
Great.
Okay.
You will also need to check the patient's blood pressure bilaterally. Differences across the arms can indicate a variety of pathologies.
That can be significant. And it's also good to just get a baseline on both arms, so you know if they're the same or if there's a difference for comparison later. Next, you assess the patient's jugular venous pressure, or JVP.
The jugular vein sits on top of the right atrium and provides an indication of the central venous pressure.
If the vein is really full and we can see it bounding, it indicates that he could be fluid overloaded, and you see that in people with heart failure.
You can't palpate a vein. For this reason, you assess the JVP by observing pulsations in the internal jugular vein.
The internal jugular vein sits below these two tendons of this muscle here, the sternocleidoid mastoid muscle, and runs up to the angle of his jaw. So what we're trying to do is look for the flicking or pulsation of a vein, which you can't feel because it's a vein, underneath the muscle. So it's a bit hard to see sometimes. It's best seen on the right side of his neck from the left-hand side, so we can look across the horizon.
To locate the vein, you need to fill it up with blood. You do this by placing the patient flat.
You can see a little bit of a pulsation there, but it's not that easy to see. So another manoeuvre that we can do to help enhance this vein, I'm just going to push on your abdomen now. Just relax for me, if you would. As I push, you can just see this whole region rise up there. That's the vein filling up just underneath his neck. Can you see that?
Yes.
Okay.
If you are unsure that what you are observing is the jugular vein or the carotid artery, occlude the vein gently with your hand. The pulsations that disappear are venous. After locating the vein, you know what you are looking for. Sit the patient up to 30 degrees.
And we look to see if we can see this flicking of the vein. And we really can't see it now. There's a bit of the carotid there, and it's not normal to see the jugular venous pressure above the level of the clavicle unless someone is fluid overloaded.
So
And
if
that's-
they were overloaded, would you see it?
Yeah, you might see it flicking. Sometimes you can see it in people with gross heart failure up above the angle of the jaw, or actually flicking out near their ear.
Right.
And the JVP is measured off the angle of Lewis, which is this bump in the sternum here. You find the suprasternal notch, which if you push on it, you'll touch their trachea, and you run your fingers down the sternum, and there's a little bump a couple of centimetres down, and that's where the manubrium and the sternal body join. And if you run your fingers across from that bump, this angle of Lewis, you feel a second
Remember,
rib.
you measure the JVP with the patient at 30 degrees.
The angle of Lewis.
Draw an imaginary horizontal line from where you see the vein flicking in the neck.
And measure.
The vertical distance in centimetres from the angle of Louis to that imaginary line is the JVP measurement. The normal heart sounds you should hear are S1 and S2. The S1 is the sound of the mitral and tricuspid valves closing. The S2 is the sound of the aortic and pulmonary valves closing. The four areas of auscultation are aortic, pulmonary, tricuspid, and mitral.
And it's a good idea too, when you're learning to listen to heart sounds, is to feel the person's pulse at the same time, because S1, the first heart sound, you hear with the pulse, and S2 you hear as the pulse diminishes.
Right.
Because S2 is the sound of the tricuspid and mitral valves. Sorry, S1 is the sound of the tricuspid and mitral valves closing at the beginning of systole when the heart contracts, and S2 is the sound of the aortic and pulmonary valves closing at the end of systole, the beginning of diastole. So you hear them just as the pulse diminishes.
Okay.
And it's a good idea to listen with both the bell and the diaphragm. The diaphragm and the bell. The diaphragm you hear higher pitched sounds more clearly, and the bell lower pitched sounds. But there's several manoeuvres you can do to enhance the sounds that you're listening with your stethoscope. And so
These manoeuvres involve repositioning the patient and asking them to hold their breath.
heart sounds.
This makes the heart sounds easier to hear.
So Andrew, if I can get you just to lean forward for me. And so the aortic region is the second intercostal space on the right sternal edge. And if you just breathe in and out and hold your breath, please. And it's a good idea to feel the pulse at the same time, because that can help you decide which is S1 and S2. Okay, breathe away, thank you. Sounds quite normal. Do you want to have a go at that region, Joe?
suprasternal notch, and then downwards
Yeah.
to where the...
If you just rub your fingers up and down his sternum, it's easy to feel the bump there.
Oh, yes,
There
yeah.
you go. That's it.
And then across is the...
And you should feel a rib there, which will be your second rib. So just
then in this space here is where I want to put my
that's right. It's
stethoscope.
between the second and third rib, so the second intercostal space.
So it was in there.
Yeah. So he needs to lean forward now.
Can I get you to sit forward, thanks, Andrew? And if you could breathe in and out and hold your breath, please.
That's it. Feel his pulse at the same time.
Right, yeah.
You'll hear lub-dub, but the sound that's slightly louder will be the one that you hear as the pulse diminishes, because that's generated by the aortic and
Aortic.
pulmonary valves, so we hear them loudest up here.
Right.
And then when we listen down here, the sound that we hear with the pulse will be slightly louder,
Louder.
because it's generated by the tricuspid and mitral valves closing.
Place your stethoscope over the second intercostal space at the left sternal edge.
And now you ask the person to breathe in and hold. Great, thank you, Andrew.
So, is that the angle fluid there?
Just there. So
There.
this is his, around there is his second intercostal space.
And if you could breathe in and hold your breath, please. Yep.
So,
So,
wait to-
is there a reason why you get him to hold his breath for that?
It actually increases the acoustics in the chest.
understand.
And the other thing, when you breathe in, if you're listening to the pulmonary region, you get what's called splitting of the second heart sound. So the aortic and pulmonary valves close at slightly different times because of the change in intrathoracic pressure. So you can actually hear S2 become a little bit longer in duration.
Right.
And so if you can hear that, you'll hear it when they breathe in. And a way to remember whether the person should breathe in and out and hold or just breathe in and hold is to think if when you're listening to the valves on the right side of the heart, so the pulmonary and tricuspid, if they just breathe in and hold.
Okay.
And when you're listening to the valves on the left side of the heart, the aortic and mitral, if they breathe in, out and hold.
All right.
Place your stethoscope over the epigastric region.
Can you breathe in and hold again, please? Great, thank you.
And then for the next one in the epigastric area.
Yeah, just around there, the bottom of the sternum.
And I'll get you again to breathe in and hold your breath, please. So with that one, the louder sound is with the pulse beat. Is that correct?
Yeah, that's
Yeah,
right.
that's-
So as you hear it, so that's S1 or the lub.
The lub.
Very good. And it's not easy to hear heart sounds often. Now, if you can just roll onto your left-hand side for me, just roll over a little bit towards me.
Place your stethoscope over the fourth
That's
intercostal space, mid-clavicular line.
And so then that's the mitral region. If you breathe in, out and hold for me. That's great, thank you.
So in and out and hold your breath, please. Yep, nice and clear.
Yeah, it's much clearer that way. You lie back straight in bed for me, Andrew. And so when we were listening to his chest, have we heard any murmurs, any abnormal whooshing sounds? If it was loudest here, then we assume that it's probably the aortic valve. If it was louder over here, well then it's a mitral valve, because that's where we hear it. We might hear it everywhere, but where it's
Sound.
loudest, that region tells us it's related to that valve.
Right. And if it had like an artificial valve, would that sound different? Can you?
Yeah, it would depend whether it was bioprosthetic or not. Then that would just sound, we wouldn't really hear much of a difference. If it was mechanical, we'd hear a clicking noise. Sometimes you can hear that from the foot of the bed.
Following are some sounds that indicate cardiac pathology. After listening to the 4 valves of the heart, you palpate the point of maximal impulse, or PMI. The PMI is located at the 5th intercostal space, mid-clavicular line.
Yeah, it's the tip of the left ventricular apex, so it's called the point of maximal impulse.
Can't quite find it in here.
Just try. Just there. Maybe use most of the balls of your pads of your fingers.
Oh yes. You can actually feel it.
Yeah, and so it should be mid-clavicular. If it's displaced around here, that indicates the left ventricle's enlarged. And dilated cardiomyopathy.
Okay, so healthy part there.
So it's where it's meant to be.
Following the assessment of heart sounds, you assess the lungs. The lungs are an important part of cardiac assessment. An assessment of the lungs can help you differentiate between cardiac and respiratory pathology. Refer to the respiratory session for instructions on how to conduct this assessment.
Well, that's it. We've kind of finished. Thanks, Andrew.
Becoming skillful in cardiac assessment takes practice.
So we didn't really find
Following the
anything.
systematic approach of looking, touching and listening over each part of the body as demonstrated is essential in developing your confidence in cardiac assessment.
Right. So it might not have been anything too serious.
Might not have been, but we'll wait and see. And then there might be further investigations that we'll do over the next day or two to work out what's going on.
Okay, sounds good.
Okay.
Thank you.
Thanks
Thank
a
you,
lot for
Andrew.
your help.
You're welcome.